Thank you, Steve. So I've known Kurt Andersen for almost a decade, back when he helped lead the SRE function at LinkedIn. And he's been a member of the DevOps Enterprise community ever since. And I was so delighted, and to be honest, astonished, when he submitted a talk proposal with one of his colleagues at Blameless, Christina Tan. They wanted to share the learnings from Dr. Alvarez, who is Clinical Assistant Professor of Emergency Medicine at Stanford Medicine. And he will be talking about how it is sometimes surprisingly difficult to apply principles of blamelessness and compassion in the context of medical professionals. There is so much about his experiences and expertise that defy easy explanation, and I am so excited about what he will be teaching us today. He will be co-presenting with Kurt Andersen, who is currently SRE Architect and Head of Strategy at Blameless, along with Christina Tan, who facilitates strategy and executive alignment. Here's Dr. L.A., Kurt, and Christina.
Imagine you're in a resuscitation in the emergency department. The ambulance brings in somebody gasping for air. It's the pandemic. You and your team are getting ready to resuscitate. As a team leader, you're orchestrating medical interventions while also making sure about your staff's safety. This is a very common scenario for us in the emergency department. We make high-stakes decisions in high-risk environments. Medicine is a VUCA environment. It's volatile, filled with uncertainty. We're not sure who's coming to us and with what diagnoses. It's complex, including their disease processes. Is this COVID or is this just a collapsed lung? Maybe both. And so we work with a lot of ambiguity. There's a saying in medicine that patients do not read our textbooks. They present with vague symptoms, and it's on us to discern which symptom or physical findings are relevant. We don't always know whether interventions will work until implemented. In my line of work, mistakes can mean life or death. And we do this several times over our shift, one after another.
That sounds incredibly challenging. And there's a relatable but not equivalent parallel in IT. Sometimes an incident could cost a company millions of dollars, and the engineer who unintentionally triggers that VUCA process would have challenging feelings that are very difficult to resolve.
As John Alspaugh, who happens to also be on the program agenda for this conference, has pointed out, incidents are unplanned investments in our systems, and it would be a waste of that investment if we did not learn from it. So what can we learn about working through and analyzing IT incidents from the high tempo, very high consequence world of the medical emergency departments?
And what does vulnerability have to do with team collaboration and creating a learning organization? These are the topics that we'll be exploring today with Dr. Alvarez and Kurt. First, a round of intros. Hi, everyone. I'm Christina. I'm on the strategy team at Blameless, strategizing for market positioning, executive team alignment, and building a culture of high performance and connection. I'm passionate about showing how Blameless culture can work for not only engineers, but also business leaders.
And hi, I'm Kurt Andersen. I've been an SRE since before the term was coined by Google, working at a variety of organizations. Currently, my title is SRE Architect, and I'm the head of strategy at Blameless.
My name is L.A. Alvarez. I'm the Director of Wellbeing at Stanford Emergency Medicine. Clinically, I'm an emergency physician at Stanford. Also relevant to this talk, I serve as the Associate Residency Program Director, focused on quality, patient safety, and process improvement. I also serve as the co-chair of the Physician Wellness Forum at Stanford WellMD. By the way, we're among friends here, and so please feel free to call me by my first name.
So LA, tell us how retrospectives are typically done in your emergency department.
Thanks, Kurt. There are two main types of retrospectives for me. The first one is on shift immediately after the incident, which I'll refer to as debriefs. Then there's the case reviews for critical events. There's a team that meets twice monthly to review cases.
Well, let's come back to case reviews in a little bit. Tell me first a bit more about the on-shift, in-the-moment debriefs.
For debriefs, I try to gather the team so we can reflect on how we did. This is very different from my training in the Bronx in New York City, where we rarely did debriefing after any incident. As a resident, I remember we would talk about cases in subways, on the way home, or at gatherings. Now at Stanford, our nurses even ask for this. It's simply just part of our culture.
So who all do you pull in when you say the team?
Yeah, so for on-shift debriefs, the whole team is invited. The nurses, physicians, the techs, the respiratory therapists, pharmacists, really anyone who was in the room, including the social worker.
That seems like it would take quite a bit of time. How long do you dedicate to these events?
Yeah, this is the challenge. We often do not have the time to do this as there are constant influx of patients in the emergency department. However, we're very intentional about this, and we would spend about 5 to 10 minutes, maybe 15 minutes max if it's a challenging case.
Thank you for sharing an overview of Debriefs LA. Let's dig in some more. Confronting a negative outcome can be very stressful, especially when a person feels some degree of personal responsibility. So LA, how do you alleviate the emotional trauma of post-incident debriefs?
I think it's important to preface debriefs. During this gathering, I say something like, hey, I know we've done multiple debriefs. Here's the structure that I want us to use today. Let's comment on the individual, then the team, then the environment. Because we are all showed up today with the goal of saving people's lives. When we talk about the individual, please focus on yourself only so that we can avoid pointing fingers. The next key part is vulnerability. This creates psychological safety and provides a clean framework for the discussion. Before I did this, I would either get a lot of kumbayas or kudos that were very superficial. Great job, what a team. Or the opposite, where people blamed each other. And so when we leave the debrief, you're feeling frustrated and angry. And so, for example, I start with a mistake that I made. There's always a mistake or opportunities for improvement. So I pick one. Everyone makes mistakes because, again, VUCA environment. We're doing the best we can in the information that we have in the moment. I pick something that I can normalize to everybody. Like, I'm not sure if you noticed, but when the patient arrives,